Time for some clinical peanuts.
We got a lot of feedback that people are still not clear about toric and astigmatism, and we wanted a perspective which was beyond the institute level, because at institute we have so many instruments and all the gizmos. So whether everything is needed, how a private practitioner can go ahead is so we thought of whom to get in as a speaker, and no one better than Dr. Dhira, who is a consulting ophthalmologist at Jamshedpur, and he not only practices phaco and refractive but also glaucoma. And Dr. Dhira has done his post graduation from LV Prasad, Hyderabad, and I was lucky to be with him. And I think off to you, Dr. Dhira. Please take us through.
Okay. Thank you, Anuj, for a nice introduction. It's indeed a pleasure and honor that I'm presenting today on astigmatism and toric IOL. So, so what is astigmatism? Whenever we do cataract surgery, we try to, replace the refractive component. So in plain cataract surgery, whenever you are putting the normal IOLs, we are replacing the spherical equivalence of cataractus lens with whatever power by biometry, and so that is the usual cataract surgery. But nowadays, since the shift is there in the perception and in the scientific innovation in every branch of ophthalmology, so the cataract surgery is nowadays refractive surgery also. So we try to give the patient the spectacle-free experience of visual. So the astigmatism is the component which is there on the cornea. If you look at the corneal power map, you will find that the distribution of power over the cornea is not uniform. So whenever the power distribution is oriented in one axis and the other axis is steep or the flat, which is there at 90 degrees in most of the cases, what we called it as regular astigmatism. So this residual power over the cornea, which is there in in significant number of patients, this is being attended along with the usual cataract surgery, and that surgery we call as toric surgery, toric IOL, or the cataract surgery with toric IOL. So nothing special. The only thing is astigmatism is a vector. So it's having both the component, the magnitude as well as direction. So the toric IOL is essentially astigmatic IOL, wherein with the calculation, whatever astigmatism is there on the cornea, with the unique kind of calculation, we try to figure out a toric calculation with which we need to implant the toric in a way that will nullify the effect of the corneal astigmatism. So it is to correct astigmatism. The significant number of the patient coming to us for cataract surgery are having astigmatism more than 1.25, and around 1/10 of the patient are coming with high order astigmatism around 2 diopter range. So the goal is always the same. We want to give the best visual experience to our post-op to our patient. We are utilizing the best of the science, whatever available in terms of technology, in terms of surgical, technologies and all. And last but not least, we all want to earn a little more money. So this is in premium. So what is unique about toric is, if you look at from the perspective of premium lenses, the uniqueness lies in the other two lenses, which falls into the premium lenses, are multifocal and EDOF, wherein some bracket of reservance is there. I mean, in multifocal, patients explain to the patient, and sometimes the patients are not happy because of the unknown reasons also. And in EDOF, since the patient are having slightly more than usual near vision, So most of the patients complain about the near vision in a dog. So unlike those toric IOL, you will have always the happy patient if you have implanted well. So what determines success in toric IOL is, of course, surgical technique, especially in some subsets of cases wherein the jonular compromise or jonular weakness is either there or anticipated, like in the case of pseudoexfoliation, and wherever the chances of progressive meiosis, like in the case of IFIS or idiopathic floppy iris syndrome, where the progressive meiosis is there, which will not let you to judge the right alignment of axis after the surgery. These are the some subsets of patients, some subsets of cases where surgical techniques of course counts more. Otherwise, the surgery is remains the usual cataract surgery. IOL brand does not have difference. As per the larger study, the rotational stabilities of almost all the lenses are almost similar. What determines success in toric IOL is the calculation, pre-op calculation, the understanding of corneal power and all. So if you will look at K values or the keratometric values, you will find that most the traditional ways to analyze or look at the K value or astigmatism is wherein we are counting only for the anterior corneal astigmatism or the anterior corneal power. But what determines success is when we have now the understanding of posterior cornea also, and in the posterior cornea there is some astigmatism over there also. So interference of the posterior corneal astigmatism in the unique way over the anterior corneal astigmatism determines the success mostly in the toric IOL. So as the distribution of the anterior corneal power you can see is there. Similarly, the posterior cornea is also having some power distribution. Like in this case, you can see 6.5 is here and 6 diopter is in the horizontal axis. So what is unique about posterior cornea is in most of the cases, the steep axis lies in the horizontal plane and it doesn't change with the age. So aging, as in the other, as the anterior corneal astigmatism, you will see that the aging changes or shifts is there in the anterior corneal astigmatism, which is not there in the posterior corneal astigmatism. So newer biometry formulas incorporate the posterior corneal astigmatism also. Now look at this is the photograph from the pentacam, wherein you can see this is the anterior corneal astigmatism. So K1 and K2 is 41.6 and 43.2. While the posterior corneal astigmatism also has some numerical data. So along with these two, the biometer tries to figure out what astigmatism actually needs to be corrected. So this understanding and calculation is very important in the calculation of toric IOL. So similarly, this is the calculation from IOL Master 700, wherein you can see this is the K value and this is total corneal astigmatism with the adjustment of posterior corneal. So what is unique about posterior cornea is mostly the astigmatism lies in the vertical plane, has negative or concave effect, and it plays a significant role, especially in the lower order, lower astigmatic values. So whenever you are going to correct 1.5 or less than 1.5 diopter of astigmatism, there the posterior corneal astigmatism plays a significant role. So once you know that what is the K values, you just need to use any online calculator. There are a number of all the companies are having online calculator, and most of them uses Barrett formula to calculate the final findings. So here you need to put your all the datas like axial length and K value, steep axis, and your SIA. We will talk later on about what is SIA and how do we calculate SIA. So with this all, you will get some calculation sheet wherein the sheet will tell you about what is the residual. So you are intending to correct all the astigmatism, but it is not mathematically possible always to to negate all the astigmatism. Some of the power will remain over there, and you need to choose the model on the basis of your perspective, that in which axis you want to leave, or what is the residual that you want to keep over cornea. So here in these two diagram, you can see these two photographs. You can see that astigmatism is same. So rest everything I have kept same. The incision. So the same calculation. So this is how you will be able to calculate and decide. So this is the same. So changing the absolute value is not going to change the calculation per se about your incision, and SIA is same, then you will get the same axis of orientation. Now what is flipped axis? So flipped axis is whenever you are planning for a toric IOL, in the calculation sheet, you will find that mostly the residual lies in the here in this case, if you will see that astigmatism lies in the 24 or 30. So this is the steep axis. 30 degrees is the steep axis wherein the residual lies. So when you are changing the calculation in a way that the chosen option is where the residual lies over the 90 degree or the orthogonal axis, that is called as flipping of axis. So flipping of axis is not something that you cannot choose. It's mainly based on that what axis you are leaving the power and what is the amount of power that you are leaving over the cornea post-operatively. That consideration is important. So here you can see 24 degree is the residual, but if you go for this particular model of IOL, then the residual will be at 114 degree or with the flat axis. So this is called as flipped axis in the calculation. So the question is, do we need to measure posterior corneal astigmatism always to get right calculation? The answer is no, we do not need to calculate always. The Barrett toric calculator, the uniqueness is Barrett toric calculator uses predicted posterior corneal astigmatism. As I said that most of the posterior corneal astigmatism lies in the vertical plane, and their value is also in the range of 0.2 or 0.3, 0.4, like that. So they are having nomogram, and with the help of nomogram normative data, they use the predicted PCA to calculate the power. And if you are having latest instrumentation, you can use the measured PCA also. In IOL Master 700, the measured PCA can be used. So this is the publication wherein they said that slight benefit is there, or the outcome is better with the measured over the predicted. But some of the recent studies says that there is no significant difference between the absolute prediction error in between the calculated or predicted way of looking at posterior corneal astigmatism in the Barrett toric formula. So these are the five formula which are being very accurately giving you the calculation in the toric calculation. So almost all the formulas are giving similar result, except in against the rule astigmatism, where EVO formula stands little taller over the others. This is the EVO formula. This is also available online. These are the lenses which are available. Generally, on the corneal plane, we can look at the power from 1 diopter to 6 diopter. Commonly, these are the powers available. If you need to correct more than this, there is one company, Indian company, which gives the power range of around 10 diopter, and they customize the lens also. That is Care Group. So now, SIA or surgical, this is an important consideration, wherein you need to justify that what astigmatism can be produced by your incision over the cornea. So this depends upon the size of incision. The length of incision also is one determinant. where you are giving the incision, temporal corneal incision generally are less astigmatic than compared to superior one, because that is nearer to the center of the cornea. And surgical time and phacoenergy is also important. If your surgical time is more and you have more manipulation of the wound, then there is a chance that your SIA will be slightly more than what you are predicting. So if you are going for minimum incision like 1.8, their SIA is very, very less. In general, SIA is around 0.2 you can keep for 2.2 incision or 2.8 incision. 0.2 SIA is okay in general. So after doing the surgery, next day, if you are finding that the misalignment is there, you were intending to implant the lens, or the alignment was ideal alignment was at 80 degree, and next day you are finding that the alignment is actually at 119 or 120 degree. What to do and how to go about? Then there is a software, or there is a site where you can go. It's called www.astigmatismfix.com. There you need to put all the data, yours as well as patient's data and the manufacturer data. Once you will put the manufacturer data, and this will come in this form, and model number you'll have to put, the IOL measurement you'll have to put, what was the current IOL axis and originally the calculation. These all you'll have to put, and then the current refraction value. What is the refraction coming with this, and how much time has happened post-op? These all if you will put, then you will get something like this, which will tell you about how many degree of, how you need to orient the toric to get the ideal toric position. So before going to toric, you need to mark the cornea. What is your where is you are going to put the incision, and in what axis you are going to align the lens. So in the calculation sheet, you will get the two angle where areas where you need to mark. One is axis of placement. In this case, it is 95 degrees. So in 95 degree, you'll have to put one mark across the cornea, limbus to limbus, and the limbus this side and that side, and incision marking at 180 degrees. So you'll put a mark on 180 degree. Here you need to take the incision. So there are two ways you can do marking. The reference marking is where you are marking at 0, 180 and 90, and there on table you'll have to finally mark the alignment axis and axis of incision and the area of incision. Here you will require multiple instrumentation, or you can go directly on slit lamp. You can do the marking of direct in the alignment axis, and you can put the astigmatism or the axis of incision also. These two you can do. So slit lamp marking is good. One should learn how to mark on the slit lamp. Making the slit axis, you can do the marking. These two areas you can just put the slight marking, and on table this marking, if you are fading, you can again put a slight dots over these two areas, and this will be your orientation or the alignment marking. So it's better to do a good rexis. It is desired but not essential. Thorough visco wash after toric IOL is very, very important. It is essential because misalignment of even 1 degree will compromise the result by 3 degree. Meaning if you are getting 10 degree of misalignment, you will have 1/3 of compromise in your result. So ensure final alignment before closure. I mean, even if you are hydrating your wound, after that you should see that whether the alignment is perfect or not, because sometimes even the hydration of wound can lead to slight misalignment. So now the most important question is, new surgeon, when should they begin and how early they should start doing toric? So the answer lies in one of the large study. They did the study and they look at the result with the resident versus the experienced faculty, and the result was good. There were no significant difference. So anyone should try to do toric. Those who are doing phaco surgeries, they should definitely try for toric. So the take-home message is, well begun is half done, holds very true for these toric IOLs. So you should begin with right calculation. The understanding should be there of K values, the formulas, thorough about the basics. And then unlike focal, as I said, the toric should always be encouraged. You must counsel your patient if significant amount of astigmatism is there to go for toric. This will definitely going to give you a very good visual experience. Begin with some of the easy cases for at least 5-10 cases, unless and until you are experienced enough to take some difficult cases, then you go for the difficult. Thank you very much. I'll be happy to take any questions or any basic doubts if anyone is having.
Thank you, Nitin. That was, I think, really comprehensive, and you have made it very simple also. So you were talking about the easy cases in the start. So easy cases would be surgically easy, or would the amount of astigmatism also play a role?
No, the surgically easy cases. Amount of astigmatism, of course, should not be very much weak.
Okay.
Therein, you should not have trouble to something else. You should not be caught with the rexis and you are planning for toric and you are having trouble in doing some of the very hyper mature cataract runaway rexis is there. Then your confidence level will go down. It's better to select for initial 5-10 good cases which you are feel that you are comfortable, and those cases then go ahead with difficult one.
Okay. And would you like to tell us about your journey? Like, how did you start? Were you trained in Toric in your residency, or how did you go about it?
Not at all. I hadn't done any Toric IOL in my residency, but soon after residency, when I left LVP, I started doing the Toric because there was nothing new in Toric. The only two things you should learn before doing Toric, jumping to Toric, is you should try to learn doing bimanual IA or coaxial IA, whatever you're doing. Go behind the IOL and try to do thorough viscovas. This is one. And the second is whenever you're doing your normal phaco cases, you try to dial the IOL and try to put it in one particular axis and try to see how comfortable you are in doing so. And then you go for toric.
Okay. So roughly, what was your number count?
I believe after doing 50 cases, I started doing 100 cases, maybe. I do not exactly remember.
So here we need to keep in mind that Dr. Dhira's surgical skills are amazing, and he can use both his hands. So maybe we have to take it with a pinch of salt for everyone, because everyone may not be able to start so early. But that is, I think, a very good point. So do you feel that a specific training would be required for someone to go for a toric?
Not at all, not at all. It's just a matter of courage. You should have to mark. You do not go for toric. You just do marking in your usual cases. 2 marks for the alignment and put 1 mark for your incision. Go ahead and do usual cases. Try to align your usual IOL which you have at the end of the surgery. You take a feel, and then there is nothing. Calculation part will be taken care by most of the time companies. But if you can go with the basics, then you will learn how to calculate and all.
Okay. And
Sir, I have a,
yeah,
sorry. Sir, I
please
have
go
one
ahead.
question.
Yes, go ahead, Dr. Hard.
It's just a very nice presentation. Just wanted to ask that in your practice, what's the minimum limit above which you think about toric? And do you go for LRIs as well, or just for torics?
LRI is for the very minimal astigmatism is there, where you cannot implant 0.75 if astigmatism is there less than 1, where the dilemma is there, whether actually you want to go for toric or not. Then in those cases, you can give LRI or incision in that steep axis. And if you can give 180-degree apart also one incision, then that should be enough in those cases. So, but
Okay.
whenever the astigmatism is more than 1, then of course the proven benefit is always there with toric lenses.
So in your private practice, if the astigmatism is more than one, you definitely go for toric. But if it's around one, you go for LRIs. And if you don't mind me asking, like if you're going for LRIs, how many degrees do you go on either side of the steep axis?
See, if it is less than one, then I do not go for LRI. I just give incision in that axis. That is enough. LRI is practically no one is doing LRI for calculating because that much prediction is not there. Regression is there and everything is there. So you cannot. It sounds very fascinating LRI, but it doesn't work that way. Actually,
Okay. Okay. Thank you so much.
I think that
One
point you have covered very
thing to
well,
think about.
Dr. Nitin.
Yeah.
That LRI, there are two things which are very important. That first of all, they are unpredictable, and the regression that you may get a good result, but you don't know for how long that result is. So
yes.
if you are promising your patient, if you are in a setup where, as you said, it is a premium IOL or it is, then it can be little difficult because it is little uncontrolled.
See, in private practice or in whenever you are in practice, you patient will give you little more payment or the charges. So you want to make sure and you want to be sure that the results should be very much predictable. That something where you are not, how can you give impart confidence to your patient in while counseling for something, you know? So that is there. And this tolerance for astigmatism in multifocal is slightly less. So even for 0.75, if it is in there and at ATR, against the rule astigmatism, we counsel the patient for go for toric along with multifocal if it is whenever it is there. So in multifocal, the limit for tolerance is slightly less than usual. Patient will not have good experience, post-op if you are implanting multifocal and residual astigmatism is there over the cornea. Then the patient will have a bad experience. That is,
Okay, and you touched this point about the incision.
yeah.
So this was a question like, can we do premium IOLs and toric IOL with a superior incision? Is that
Yes, 100%. We can do. We can do. As I said you, there are larger study which tells about if the incision size is less, like 2.2 incision is hardly matters. Hardly counts, but always try to, for the new surgeons, I will definitely say ki go for and try for doing surgeries on the temporal side because you will have habit. It's better for many reasons. Like it's less astigmatic and the room is more in temporal side. Your maneuverability and handedness is having more space in temporal side. Secondly, in the deep set eye, temporal side is always good in topical surgeries and all those. Temporal surgeries should be encouraged in residency. And whenever you're coming out of residency, you try to do temporal. One or two, three cases once you will do, then you will find it's easy coming.
so? So this is, you are talking about temporal or superotemporal, like what is like as a
Right. What I do in my practice, right eye, of course, right side temporal comes. When you do from superior also, you can easily take superotemporal incision, which is very good. And in the left side, since for the right-handed surgeons, the nasal restriction is always there. So in 100% of the left eye, I do temporal. But some of the patient, right eye, I go overhead also.
okay,
Superotemporal incision sitting overhead.
okay. So you are operating with your right hand or left hand, Dr. Dhira?
Right hand.
Okay, and you can operate with your left hand as well, right?
Sometime when I was with you.
So these people have to, because Dr. Dhira can operate with both his hands, and I think probably he'll be operating two patients at one point of time because he can do surgery with both his hands. So I don't know about his eyes, how whether he can manage that. So that is a very good point that yes, you can go superior. There is nothing wrong, but it is always better to learn because when you need to change the incision and I think you have already covered, but just for the sake of repeating and explaining it further. So how should one plan the incision? where like if there is astigmatism, like you said, so how to change the incision.
So based on the K values, you can plan your incision, but sometimes the steep axis is at a very weird position in oblique situations, mostly. So you cannot take incision. In those cases, what we do, the first incision or the main incision, what we take is on the comfortable position, and we take side port incision in that steep axis. And after completing the surgery, we increase the side port to flatten that axis. Wherever we are not implanting the toric and we want to justify the surgery by doing incision over the steep axis, and the steep axis is in the way where we cannot put the main incision. There are many instances in oblique situations where on the steep axis you cannot take the main incision. So you do main incision wherever you are comfortable. Try to take one of the side port at the steep axis, and at the finish of the surgery, once you are finished the surgery, you take a 2.2 or 2.8 incision on the side port incision, and that will flatten the steep axis. That is what we do in the axis where it won't be possible to do the main incision or put the main incision.
Okay, okay. That is, I think that clears it very well. And coming to these side port, would you say that a coaxial would be better instead of bimanual, or you feel they don't make any difference? And about hitting the wound?
They make difference because whenever you are doing with coaxial, you are taking only one side port incision. So your predictability and outcome in terms of judgment of the surprises are less, of course, because the less number of incision over the cornea, your calculation and the predictability will be better. But as I said, it's all based on your learning curves, and these things doesn't matter much if you are targeting for 2 diopter of astigmatism. These discussions are not that much of value, or plus two and above diopter of astigmatism if you are dealing with. These things holds true if you are targeting at 1 diopter and premium like multifocals. Then, of course, using coaxial and giving only one incision other than main incision will give the surgery more predictable, of course.
Okay. And
Sir,
anything?
I have a query.
Yeah, please, Dr. Neha. Yes, go ahead.
So the technique you told of extending the other incision, like giving the side port incision at the steep axis. So this is what I've been doing, but I extend my incision with the side port itself. So does it like extending it the keratome gives extending it with the side port? Because I do that with side port. Whenever I cannot give incision
You
the
do
steep
with
axis.
Whether you do with keratome or side port, it's the incision size which counts most,
Acha, okay, okay,
and
sir. Okay,
incision length which counts most. And
okay,
based on what is the amount of astigmatism that you are looking at to be corrected with your incision is also very important perspective. So
okay,
more than 2 or 0.2 or 0.4 cannot be expected to be corrected over the period of time with looking at the regression and all. So if you are targeting at 0.5, then try to give incision at
okay,
your
sir.
axis of incision, and 180-degree apart also give a side port and give it also keratome of 1.8,
Okay,
maybe a little more than that.
okay, okay, sir. Okay, thank you. Thank you.
Hmm.
I think Dr. Neha, I think Dr. Dhira has cleared most of your doubts.
Yes, sir. Yes, sir. Thank you so much. Yeah.
Okay. Okay.
Okay.
Okay. So, uh, do we have any other questions? We'll just see the chat box, Dr. Nitin.
Yeah.
And so, why do we need to calculate repositioning uh, front the astigmatism from the calculator? Can we not just put it in the same axis which we were planning to when
No.
it has shifted or the IOL is not in place in a toric?
In that, it's better. It has been seen with the studies that it's better to go with the advice of astigmatism fix, because then the residual astigmatism and the duration of surgeries also counts a
Yes.
lot.
So it is more
And then
predictable.
and all, what is the finally it's coming the refraction. You are having better chance to correct it in better way.
Yes.
Of course, you can do the same. Next day, you can dial it on the axis which were given or which were planned. But if it has happened, say the patient is coming to you after 2 weeks and some sort of regression is being in your consideration, then it's better to look at refraction, put all the data, and of course you can see the previous chart also, what was there, and with the newer suggestion, and then you can apply your own calculation where I should do and what I should do.
Okay. Okay. So another question is, after visco wash behind the IOL in the end of the surgery, will the IOL position change?
No, once you have thoroughly washed the visco, there is no point. I mean, they generally does
Like,
not. But one caution is there: if you are doing toric in very myopic eye, wherein the bag size is bigger, then of course the chances of misalignment is slightly higher than normal usual cases. So if you are doing toric or planning toric in high myopic cases, you must tell or counsel your patient that the chances of misalignment is slightly higher than the normal cases. We may need to align your lens in the second stage. That is it.
okay, so can you share a video for make marking maybe next time when
Yeah,
we catch
next
up,
time.
or maybe you can upload, give us a link in the group.
Yes. Yeah.
Okay, sir. How to calculate the surgically induced astigmatism of my incisions? I do try to.
There are website, but if you are doing clean 2.2 incision, mostly SIA comes is around 0.3 or 0.2 with the regression taking into account. But usually new surgeon, they used to give 0.5, 0.4 with the apprehension. But with the experience, you will get to know that it's hardly 0.2 or maybe even less. The best surgeons across the country, they are putting only 0.1 as a long-term regression. This coming only 0.1 correction. So SIA put it at around 2 or 0.3 maximum. If you're taking superior incision, put it 0.3. And if temporal, put it 0.2 in your calculation.
Okay, so we don't need to actually calculate it, and
There are nomogram, but
like I think during residency also there was.
there are apps, there are website which will tell you to put your 100 datas or 50 datas, and you will put the post-op refraction, pre-op K value. If you are having that much time, and finally you'll get the same. 0.2 is the result you will get. So I do not want to indulge into that much work. But if you are having time and patience, then you can of course go.
Yeah, both patients and patients to complete the data.
Yes, all the things are
Yeah.
important.
Okay, so how to manage more than 6 diopters of astigmatism?
Yes, you can think of 6 diopter with the IOL and slightly more, than try to do LRI or nomogram. And if it is more than that, then you can of course look at care group. They are providing up to 10 diopter.
Okay, okay. So,
Or you can think of some piggyback lenses. Some of the companies are coming with.
okay, so putting 2 toric IOLs, would you?
No, I mean one plain and one only toric, or one toric and then calculate and put another toric. This is also people are trying.
Okay. So, is there anything like a good cylinder which can be beneficial to the
But
patient?
my view in this is that if the patient are having more than 6, many a times the vision is slightly less than the normal. They are usually land up with your full refraction also, they are coming to around 618 or 612. So even if you leave some amount of astigmatism and correcting 6 or less than 6, that would also be justify your surgery. What is
Okay.
another?
Yeah. So, another question is there something like a good astigmatism? Do you leave it, or you have a very nice?
Yes. Something like good astigmatism is conceptual point. If you are leaving some astigmatism in the vertical plane, that is with the rule astigmatism, it's very much are having better contrast in the if you are leaving some astigmatism residual in with the rule astigmatism.
So you feel that with the rule astigmatism is a good astigmatism?
You can leave up to 0.5 if you're leaving. It has been seen with the monofocal lenses. We have done some short studies where we were looking at residual astigmatism with the monofocal IOLs, and we found that if you're leaving 0.75 astigmatism in the vertical plane, patients are having good near vision also.
Okay.
They are having N8 without correction with the normal lenses, IQ and all.
So then you can charge more for the same package.
Not do that way. This is
Okay.
good that
Right. And so you mentioned 2.2 keratome. So what about someone who's using a 2.8 keratome? Can
2.8 and 2.2 slight, maybe if you are using 2.8, then you should put your SIA as 3 in the vertical and 3.5 maximum in the
okay.
uh,
And
temporal.
so again, a very practical question that a young ophthalmologist who has just started doesn't have all the equipments. So he's doing his biometry with the immersion A scan and K reading from a ARK machine because he doesn't have an optical biometer and he doesn't have a pentacam or a topography. So yes or no, should he go for a toric or?
Yes, perfectly he can go for it.
Okay, so that is very reassuring, Dr. Dhira, because
Yes, because I was doing so many toric only based on ARK values, and the results were good. And even the larger study, there are many studies, those who have compared IOL Master 700 along with the AR values results, the prediction. Because those data are also going to be kept in Barrett-Toric calculators. In Barrett-Toric calculator, you will put the predicted PCA and they'll give the result. And finally, you'll find that almost similar results are coming.
okay. So not to contradict or this, so if someone is already doing with ARK and immersion, so what will be the year to go for a IOL master? Uh, is it the speed or
That is the role is when you want to do multifocals
okay?
or read off and you want to charge very robustly. You do not want to leave any because you are charging 1,20,000, 1,30,000 people are charging for one surgery. So there you do not want to take any risk. Unlike your immediate residency, where probably in your toric you will charge say 30, 40,000 and you're putting Indian toric IOL, but the results are good. But again, that happens in similar way you are charging it. All depends upon how much you have charged. And that
Yes.
we'll have to provide the best of the best science.
Absolutely. So it is more like a how you are presenting yourself and what type of practice you are into, and
Yes. And of course,
definitely
superiority is always there with the latest instrumentation. The superiority is there.
yes,
But
and you are relevant also, and I think you will get more exposure in the conferences as well. So you don't at night you sleep well if you have a
yeah,
oil master.
yes, yes.
But
There's
you can
one,
master
yeah.
IOL without it also. That's what Dr. Dhira has said. So,
Yes, of course you can.
okay, I think that is a very good point because generally what we are seeing is people are trained in big institutes. They are only used to these things. So when they come to the real world, it is very difficult to transition. And that is where people are struggling in the practice also with so much investment, and they feel somehow that it is not working. So I think that was a very important point, and good you could explain it very well. So do we have any more questions? Good video right from marking. Yes, Dr. Dhira will share. And is it possible to take up cases with 0.75 astigmatism? What could be a expected result post-operatively if we do so?
0.75 if you are looking with your ARK value or anterior corneal astigmatism only if you are looking, and if it is ATR, then the value will be definitely more than 0.75. I'm repeating again. If you are looking, if you are doing astigmatism, if you're looking at with your ARK values, auto-ref values, and if it is the steep axis is there in horizontal line, then it is or the against the rule astigmatism, then the value is underestimated. I mean, the astigmatism actually will be more than 0.75. It will be somewhere around 0.9. And again, if the reverse is also true, if the plane is in the vertical plane, then actually it is not 0.75, it is around 0.6. So, of course, 0.6, you can correct some amount with your incision in the steep axis. But if it is 0.9, then of course, if you are implanting a multifocal, then definitely you should go for toric multifocal. And if you are implanting a monofocal, then based on your patient's perspective and your counseling, your all the things will come into play. I mean, how the patient is looking at, how robustly patient is, ready to give you extra money for that much correction. Those all things you'll need to keep into mind before doing that.
Okay, I think last question before we let Dr. Dhira relax. This is a EDOF Toric IOL. Are you recommending or better to avoid?
EDOF toric. EDOF toric.
Yeah.
Any multifocal, any presbyopia correcting lens, it's better to correct everything because the perspective in EDOF or multifocal is spectacle free. How can you think of giving an EDOF and leaving astigmatism over the cornea? There is no point.
Absolutely. So when
Because the major perspective is you want to give.
refractive,
So,
so yeah, when we are talking about a refractive surgery, we need to be 100%.
so the tolerance in EDOF will be slightly. In EDOF, you can take at around 1 or 1 plus if it is there. Then you think for toric EDOF.
Okay. So I think that is a very valid point because you are promising a premium and a refractive surgery, so you have to give 100%. And so, is there any other questions? I think we have answered most of the questions. There is one query about probably a MCQ. I think, do we have any other questions for Dr. Dhira? I think you have answered all the questions, and tomorrow Care Group and all the toric manufacturers are going to thank you. So, with there's one question about EDOF lenses. I think can we take it, Dr. Nitin?
What, pardon? Couldn't get the
So,
question exactly.
yeah.
What is the
So
question?
it is a 45-year-old female with a posterior subcapsular lens with a 1.5 diopter with the rule astigmatism. In such case, is there any way to achieve better near vision other than EDOF toric and multifocal toric?
Can you repeat the question once again?
I'll just forward it to you, Dr. Dhira. It is a big question. It is, I think, a MCQ.
Okay. Let me see then.
Yeah.
You have forwarded it to me.
Yeah.
It's not there. Come on.
1 second.
No, it's not on my WhatsApp. You have WhatsApp me.
Yeah, I've forwarded just before the seminar started. I'll just send it to you again. Yes, Dr. Deepak,
Okay.
you have some
Question
questions?
was there. Okay. Yeah, one question was there. Yeah.
Yeah.
So this question, I came across the question who is teaching 45-year female with PSC. Both eye 1.5 diopter with the rule astigmatism. Correct. This is the question you are talking about.
Yes, yes, yes.
So in this question, is there any way to achieve better near vision than the IDOF toric or multifocal toric? So you see, with the rule astigmatism is there, as I said, it's 1.5. You go with advanced monofocal like Clarion or iHands and correct some amount of vertical astigmatism. Do not leave 1.5. Target to correct as much as you can correct, because this is 1.5 and you do not want to give toric also. So as much as you can and leave whatever vertical plane and with the rule astigmatism you are leaving. This will give slightly better near vision if you are going with Clarion or advanced monofocals, apart from IDOF.
Okay.
So what would be the astigmatism if you put IOL by considering K1 value 23? In the first point, now the question is there K value is same. There is no astigmatism. What would be the astigmatism if we put IOL by considering given this question or the
I think we'll take that question.
hello.
Yeah. No, the internet is unstable, I think. So
Meaning, the one who had asked the question is there with us today in the okay, no problem. So
yes, Dr. Dhira, am I audible?
yeah, you are audible.
Okay, okay. I think there's a little thing with the internet. So maybe I'll
Okay.
just push that question on WhatsApp to you, and if there's anything, I'll just put it in the group. So I think the session has been really, yeah, encouraging and very eye-opening, that because it is most of the residents, once they come out, they feel that they cannot do any surgery in the real world, because everything is now refractive and they cannot do toric, or they have to do a 1 year fellowship and they have to invest. So the points which you have been told, and all with the evidence-based literature, that it is really that depends on one's skills and one's, as you say, courage. So it definitely takes time, but if you are sure about yourself, then there is nothing like going for a toric IOL. So I would like to thank Dr. Nitin for sparing his time, and everyone for joining, and we'll catch up again with a new session. Thank you, everyone.